So we'll move on to our next speaker, Dr. Nikhil Pandey. He'll be presenting on how, so we all know immunotherapy has taken a good place in advanced lung cancer. So how is it changing the early lung cancer space? That is what Dr. Nikhil Pandey will be talking about. So if you can take over.
Yes, ma'am. Can you share my slides?
Yeah, sure. Takes a bit. Please share slowly.
So good evening, everybody. Thank you for the organizers. I'll just talk about how is immunotherapy changing the early lung cancer space. Next slide. We all know that newer treatment options have chances of improving survival in lung cancer. So basically, what this NEGM paper, which was in 2021, shows that the incidence, although is decreasing, there is incidence has decreased annually approximately 3.1%, but the incidence-based mortality also is reducing in lung cancer. So basically, I want to say that we are moving forward in lung cancer. Next slide. So this is something which we all know, that immune checkpoint inhibitors have shown improvement in advanced NSCLC, and the 5-year OS has improved, especially in those with PD-L1 more than 50%. Next slide. And there are addition of locally advanced NSCLC also, where durvalumab has improved the PFS rate from 42 to 43% approx, from 33%. So immunotherapy is there in advanced NSCLC if you take stage 3 as well as stage 4. Next slide. But if you look at the early stage lung cancer treatment options, you would consider either surgery plus chemotherapy, chemoradiation in certain cases, surgery with targeted therapy, chemotherapy plus or minus immunotherapy, surgery and immunotherapy. So the last two are the questionable things which we will address. The other points we already know. Next slide. So there is always, in any solid tumor malignancy, I think there's a doubt whether adjuvant versus neoadjuvant. Adjuvant allows the fastest time to surgery, no risk of pre-surgery complications from systemic therapy, enables longer treatment duration for systemic control, and more flexible timing post-surgery, provides more recovery time for patients. Whereas neoadjuvant approach provides earliest opportunity to eradicate micrometastatic disease, increase treatment initiation rate and compliance. Pathological response provides early indicator of response to therapy and can guide future treatment decisions, and can potentially eliminate live tumor cells released into circulation during surgery. Okay. Why do we need immunotherapy in early lung cancer? So chemotherapy improves survival by only 5 to 10%. Relapse rate is very high with only surgery, and many patients do not receive adjuvant therapy. So approximately 52% did not receive adjuvant chemotherapy in a retrospective analysis of 831 patients. Next slide. So adjuvant treatment, stage 1A, I think we all agree on observation. 1B, 2A, medical oncology consult to discuss observation versus chemotherapy. I think we'll err on the side of chemotherapy. Stage 2B, chemotherapy, yes. 3A, 3B, chemotherapy or sequential chemotherapy and radiation in N2. Next slide. We all know there's adjuvant chemotherapy in early lung cancer. There is LACE trial, and we know that adjuvant chemotherapy has provided the benefit, although the benefit increases as the stage advances. Next slide. But what about immunotherapy in lung cancer? So major progress with immune checkpoint inhibitors in metastatic as well as consolidation stage 3 NSCLC are encouraging to study them in early lung cancer. Preclinical evidence suggests that neoadjuvant ICI should be more efficient than adjuvant therapy. It is thus very important to see how ICIs in clinical trial will help improve the cure rates in early lung cancer. Next slide. What will be the benefits of adjuvant immunotherapy? The primary goal of adjuvant therapies to treat micrometastatic disease, prevent recurrence, and allow for the primary tumor, which is the source of micrometastatic disease, to be removed as early as possible. Immunotherapy is relatively well tolerated as compared to cisplatin-based chemotherapy and offers a potential for a durable, long-lasting anti-tumor response. Next slide. So what are the trials which showed positive response in adjuvant settings? There is the IMpower 010, which was the primary result in phase 3 global study of atezolizumab versus best supportive care after adjuvant chemotherapy in resected stage 1B to 3A NSCLC. Next slide. So the study design was simple. After offering cisplatin and pemetrexed or gemcitabine or docetaxel or vinorelbine 1 to 4 cycles, 1:1 atezolizumab versus best supportive care, and survival was the follow-up. Next slide. So what it showed is, the DFS in PDL1 greater than 1% patient stage 2 to 3A population. If you look at the median DFS, it was not reached in atezolizumab arm versus 35.3 man. Stratified hazard rate of 0.66% and a p-value of 0.004. So definitely, even at 2 time frames, that is 24 months and 36 months, the atezolizumab arm did better as compared to best supportive care. Next slide. And in all randomized patients, with irrespective of the PDL1 status, it was 42.3 versus 35.3, which was still good enough, with a hazard ratio of 0.79 and a p-value of 0.02. Next slide. If you look at the subgroup analysis, and if you look at the PDL1 status, if you have more than 50%, definitely your hazard rate is much better. If more than 1%, it is at 0.66, and less than 1% is the one where the benefits are actually not seen. Next slide. Let's have a look at the ongoing trials. So there are multiple trials. IMpower 010, we have already seen the completed AEGEAN. There is an ANVIL trial which is also completed AEGEAN. It is adjuvant chemotherapy. The intervention arm is CT, NR, RT, again, which was permitted here. Sequential nivolumab versus observation for pembrolizumab. There is the PEARLS trial. There is BR31, which is for sequential durvalumab versus placebo, and the Alchemist trials, which is concurrent pembrolizumab followed by pembrolizumab versus sequential pembrolizumab versus observation. Next slide. What is the use of neoadjuvant chemotherapy? Preoperative chemotherapy for NSCLC systemic review is a 10% reduction in distant metastasis at 5 years, 13% relative risk reduction of death, 5% improvement in 5-year OS, and a hazard ratio of 0.87. Next slide. And why immunotherapy will be beneficial in the neoadjuvant setting? Immunotherapy is comparatively very less toxic than platinum doublet chemotherapy, more appropriate for patients with contraindications to chemotherapy. Neoadjuvant chemoimmunotherapy has the benefit of higher rates of MPR and inducing response in patients who may not benefit from ICI monotherapy. And it has the potential to augment downstaging of nodal disease, particularly in patients with stage 3 disease, which in turn may improve the resection rates. Next slide. But can we think of immunotherapy versus chemoimmunotherapy? There are trials which are thinking of adding nivolumab, atezolizumab, and nivo or EP combination as well, which are going on, but we need to have a data on that. Next slide. And which are the trials which showed positive response in neoadjuvant settings? There is nivolumab plus platinum doublet chemotherapy versus chemotherapy as neoadjuvant treatment for resectable 1B to 3A NSCLC. This is the Checkmate 816 trial. Next slide. The study design was simple, adding nivolumab at 360 mg 3 weekly plus chemo versus chemo alone, followed by radiological restaging and surgery within 6 weeks post-treatment, and optional adjuvant chemo with or without RT. Next slide. If you look at the response of tumor to neoadjuvant nivolumab, there is, in this case, 100% pathological regression of the large primary lung tumor with a 35% shrinkage in tumor size. And post-treatment specimen, there was 90% tumor regression in the patient 1 and patient 5 respectively. So there was an appreciable tumor response. Next slide. And Checkmate, if you look at the PAT-CR rates, it is the intention to treat population. There is a nivolumab plus chemotherapy arm had a significant 24% PAT-CR rate with a difference of almost 22% as compared to chemotherapy alone. And in patients with resection, it was 30% versus 3%. And primary tumor only when assessed, it was 25% versus 2.8%. Next slide. If you look at the overall response rate and radiological downstaging, the overall response rate was 96, which is sort of unheard of. In 54% of the patients there was a ORR, and in chemotherapy alone it was 37%. So yes, there was a significant patients which had radiological downstaging. Next slide. If you look at the ongoing trials, there are a lot of them. Checkmate 816, as we already seen, has completed ACURATE. There's the Keynote 671, which is pembrolizumab or placebo, 4 cycles of Gemcis or cis with pemetrexed. IMpower 30, 4 cycles of carbo pemetrexed, carbo nab-paclitaxel or cis pemetrexed or cisgem with atezolizumab versus addition of atezolizumab or placebo. There's the same going on with durvalumab in the AEGEAN study. And Checkmate 77 T is the one which added only nivolumab or placebo. Next slide. We just put a short time on the AEGEAN study. It was resectable stage 2A to 3B NSCLC. All comers were stratified into 1:1 randomization into durvalumab 1500 mg plus platinum doublet 3 weekly into 4 cycles versus placebo plus platinum doublet followed by surgery, followed by durvalumab maintenance for 12 cycles more versus placebo. Next slide. And how do you monitor or prevent recurrences in resected patients? Identifying and treating MRD can prevent recurrences. So in the Abosh et al. In the Tracer X study, 24 NSCLC patients followed longitudinally after resection, 14 identified as MRD positive, and 93% of which experienced disease recurrence. 10 identified as MRD negative, only 10% experienced recurrence. In the Chaudhary et al. Study in the same year, there were 37 cancer patients receiving curative intent therapy, 17 identified as MRD negative, out of which only 1 developed recurrence, versus 20 out of 20 who were MRD positive developed recurrence. So there is something like an MRD monitoring which might be possible in NSCLC as well. Next slide. And these are the patients that high risk who can, to avoid recurrence, we can consider MRD negative patients of no further treatment versus MRD positive patients of additional earlier treatment, that is either IO or chemotherapy combined. Probably this will help in improving the long-term outcomes. Next slide. So what are the trials which are evaluating IO in MRD positive patients? There is a Mermaid trial, which is a double-blind placebo-controlled study of adjuvant durvalumab plus platinum-based chemotherapy in completely resected stage 2 or 3 NSCLC. So post surgical plasma sample at week 3 or 4, assess MRD status, 1:1 randomization between durvalumab plus standard of choice chemotherapy versus standard of care chemotherapy plus placebo. Next slide. There is also the Mermaid 2, which is a phase 3 blinded trial of durvalumab versus placebo in circulating DNA positive stage 2-3 NSC following curative intent therapy, almost with a similar design. Next slide. So in conclude, immunotherapy has become a part of standard of care treatment for patients with advanced or locally advanced unresectable NSCLC. Numerous studies are underway to determine the efficacy of ICI therapy treatment of early stage NSCLC, and ICI given in the neoadjuvant settings have the potential to induce good responses, improve resectability, and diminish rates of clinical metastasis. As well, while adjuvant immunotherapy will increase disease-free and overall survival.
Thank you, sir. Thank you so much for that talk.